Prevention of cardiovascular complications in diabetic patients is the most important treatment strategy to improve survival. The plan of management is based on cardiovascular outcome trials. There are two groups of outcome trials if you look into the glycemic control as the most important point. One based on glycemic control only, intensive glycemic control and standard glycemic control. And second, based on glycemic control plus use of a specific anti-diabetic drug. Let's look at the first group, based on glycemic control. There are four major trials, UKPDS 33, Accord, Advance and VADET. In the UKPDS trial, where intensive glucose control, hemoglobin HbA1c equal to or less than 7% was pitted against standard control, where the HbA1c was 7.9%. In the intensive glucose control group, diabetes-related endpoints were less by 12%, microvascular endpoints were less by 25%, and myocardial infarction less by 16%. Overall, there was a significant benefit of intensive glucose control. The authors followed up these patients for 10 years, and the benefit continued to exist. And if you look at any diabetes-related endpoint, it has become statistically significant at the end of 10 years. Does this mean is lower the better? The Accord study. More than 10,000 patients were randomized. Intensive glucose control arm less than HbA1c less than 6%. Standard glucose control arm HbA1c 7 to 7.9%. The trial stopped early because of excess mortality in the intensive glucose control arm. 257 deaths in the intensive control arm against 203 deaths in the control arm. This was statistically significant. But when you take the primary outcome, there was a benefit for intensive control, but did not reach the statistically significant level. The Accord study group also followed up these patients for next 5 years, and they found that the trend continued to be the same, that the intensively treated glucose control resulted in a higher mortality. Advanced collaborative group trial, there was no difference between the standard and the intensive treated group. Let's look at the veterans diabetes trial. There was a minimal benefit for intensive therapy compared to standard therapy. When these patients were followed up for the next 10 years, the intensive therapy benefit widened and it became statistically significant. So, why is it that intensive glycemic control does not result in cardiovascular disease benefit? Both the Advance and Accord trials involved high-risk patients who were 8 to 12 years older, respectively, than the patients in UKPDS. Patients had a long duration diabetes at randomization, high prevalence of pre-existing cardiovascular disease 30 to 40%, higher risk of severe hypoglycemia in the intensive glucose lowering arm, resulting in cardiovascular complications. In Accord, there was aggressive lowering of glucose level over a short period. Hypoglycemia is associated with cardiovascular complications. It can promote atherothrombosis resulting in acute coronary syndrome. It can induce proarrhythmia resulting in sudden cardiac death. It is pro-inflammatory resulting in progression of atherosclerosis. Sympathoadrenal response can result in hypertension. All these are bad. So patients who develop hypoglycemia has got a very bad cardiovascular response. Now let us look at the second group, where the glycemic control is also associated with drug-specific benefit. When a particular drug is given, what should be the glycemic control? The empagliflozin is a SGLT2 inhibitor, which has been tried in diabetes, the glycemic control in this group of patients was only moderate, about 7.5%. Overall, significant benefit. In another trial, canagliflozin, the glycemic control was again around 7.5%, but there was a highly statistically significant benefit because of the use of the drug. When it comes to dapagliflozin, the same benefit is also seen in this drug also. So why does this SGLT2 give so much benefit? It is because the diabetes-associated ventricular remodeling can be reversed by SGLT2 inhibitors and the heart becomes healthy. 2, proteinuria comes down, thereby improving the renal function. So there are a number of benefits of SGLT2. Along with a lower glycemic control, the patient gets excellent benefit. Good glycemic control with minimal hypoglycemic events. That's a very important point when you use SGLT2 inhibitors. Reverses diabetes-related ventricular remodeling, reduces proteinuria, controls systemic hypertension, and improves heart failure. So one interesting phenomenon, when you look at the new the anti-diabetic drugs, the SGLT2 inhibitors, as well as the GLP-1 receptor agonists, it has been shown that they are most beneficial in patients who has got cardiovascular disease already existing or at a high risk of cardiovascular disease. But when it comes to patients who do not have any history of cardiovascular disease nor at high risk of developing cardiovascular disease, the benefit is actually neutral. That's a very important point. The maximum benefit of these drugs are when the patients are having a cardiovascular disease. Another interesting point is that comparison between the SGLT2 inhibitor versus the glucagon-like peptide 1 receptor agonist. It was shown that when the patients are having heart failure, the SGLT2 inhibitor scores over the glucagon-like peptide 1 receptor agonist. So that's one special advantage of SGLT2 inhibitors. So when looking at the ESC guidelines for diabetes, SGLT2 inhibitors with standard glycemic control can be taken as a class 1A indication. And GLP-1R receptor agonists also have a class 1A indication. When you look at the glycemic control in these patients, it is recommended to apply tight glycemic control targeting a near normal HbA1c of less than 7%, especially in patients who are young, who do not have any cardiovascular complications. But when it comes to patients who have got associated cardiovascular complications or long-standing diabetes, these patients, it is recommended that HbA1c targets are individualized. Those patients who are having cardiovascular manifestations, those patients who are having high risk for development of cardiovascular disease, they should target a moderate glycemic control, maybe around 7 to 8%. Avoidance of hypoglycemia is definitely recommended. Those patients who are having intense glycemic control are at a risk of developing hypoglycemia, and hypoglycemia is associated with a number of cardiovascular complications which include the acute coronary syndrome, sudden cardiac death, the progression of atherosclerosis, and also hypertension. So it's extremely important that hypoglycemia should be controlled. It's very interesting to note that SGLT2 inhibitors, even when the patient's blood glucose level is lower, they do not develop manifestations of hypoglycemia. This is a protective benefit of SGLT2 inhibitors. So friends, what is the take-home message? Intensive glycemic control, HbA1c less than 6%, reduces cardiovascular mortality in newly detected young diabetics at low risk for cardiovascular disease. That's the most important thing. Those who are young, those who are newly detected, no risk for cardiovascular disease, they should be targeted for a intensive glucose control. Intensive glycemic control increases cardiovascular mortality in patients of long-standing diabetes having or at high risk of cardiovascular disease. These patients should have only standard glycemic control. Patients with or at risk of cardiovascular disease should be treated with SGLT2 inhibitors because at a moderate glycemic control, they get an excellent benefit. Hyperglycemia in patients at high risk for cardiovascular disease can precipitate cardiovascular complications, including sudden cardiac death. Hyperglycemic events are less in patients of SGLT2 inhibitors. Newly detected diabetics at low risk for cardiovascular disease can be treated with metformin. Thank you so much for your kind attention.